Okay, we will get started. So, I guess the thought would be to open up with your medical doctor, and there's a lot of things you could do to spend your time, to make money, to research. You could go into a lot of areas. You could have been a cosmetic surgeon. You could have gone into cancer. I don't hear of that many doctors who have focused and written a whole book on Alzheimer's. Why have you chosen this path to focus on dementia and Alzheimer's of all the things you could have done with your medical degree? Why have you decided to be so focused and make this a priority of your time?
So both Ayesha and I come from a very medical background. My uncle actually was a surgeon here in Columbia University and a professor emeritus here at Columbia University, and many other family members who were surgeons and doctors, and I saw them go through their process. And to me, it seemed like repetitive behavior and not so satisfying. And you might have heard recently about the stress on doctors. The stress on doctors has nothing to do with the amount of work. We're very used to doing lots of work. It's with purpose. Those of you who were here earlier on heard me talk about purpose over and over again. When we went into medicine, we went into it, all of us, no matter how cynical of a doctor was, there was some element of service in there. Doctors don't go into this with the idea that I'm going to come out making money. They think they're pretty smart. They take these big, difficult tests, and they know that they could have gone the business route, other routes, and they know that no matter what field of medicine, you're not going to become a billionaire or a millionaire from medicine. So it has to be something more, doesn't it? So it has to be a service orientation, and you want to serve, and you want to connect, you want to talk, you want to look at somebody in their face, in their eyes, and connect. There's that component. After 4 years of medical school, 4 years of college, where you're racing from physics, biochemistry, chemistry, organic, to the test, 4 years are gone. 4 years of medical school, you're in the library day and night, not much else, and you're basically studying molecular stuff over and over again, and part of your soul is dying right there. I'm going through this, and I don't know where this is going to end up, but let's go with it. Because it's honest. It's actually coming out. Then 4 years of residency. The word residency and internship actually came from the concept that back in the past, when you were in residency, you literally stayed in-house for 4 years, 5 years, 6 years. If you're a neurosurgeon, 7 years to 8 years. Or if you were a Duke neurosurgeon, 10 years. They call it decade with Dave or something like that. So in-house, you were technicians. Profound technicians. The one solace was you felt good that you were intelligent. People looked at you as, in a good way. But it really takes a lot out of you. And then you come out of fellowships and everything else 17 years later, and you're told to see patients 15 minutes at a time, diagnose, evaluate, examine, and then give treatment. And you know that even the patients that say they don't like pills, studies have shown, when they came out of a room from a doctor that gave pills versus a doctor that didn't give pills, even the ones that actually said they didn't like pills, guess which one was rated higher? The one that gave pills. So the pressure of giving a pill is so intense. So really, 18 years, in our case, 30 years of schooling with PhD, MD, and everything else, and I'm supposed to look at you in the eye, smile. No, you gotta look at me in the eye. Pat you in the back, fake, because how many times am I going to pat you honestly in the back? 30 people in a day, and write a prescription, get you out? Really? That's why I went to medical school for? And the only satisfaction is like maybe a Mercedes or 2 weeks, gone. That's why we're stuck on a Toyota Sienna. Yeah. When we were directors of brain program at Cedars-Sinai, for the first time, and we were the directors of brain program, Alzheimer's prevention. I learned about these cars that I had no idea existed, Bugatti and Maserati and all this stuff. And one day I came out, and I always wear a shirt, no white jacket, not to create a separation between patient. And somebody threw me the key and said, "Park my car." I should have. It was a Bugatti. I should have just taken it away. That doesn't satisfy you more than 2 weeks. So we learned that quickly because we reflected on our own parents and our own family members. And then we did some service work. And the satisfaction of working in Afghanistan and Somalia and other places where we got no money, yet the satisfaction was exponential, or San Bernardino County, going to the churches, was so immense that we decided that we had to do something differently. And that shook up our paradigm. It was a paradigm shift. And that paradigm shift actually told us, even though we were just coming out of a UCSD, the #1 neuroscience program in the country, and they said, do clinical trials and clinical work and molecular work, or you're not gonna get a grant. He said, no, we're gonna take the road less traveled. And we ended up in Loma Linda instead of Harvard or Brigham or something like that. And it has paid off. We still have the Toyota Sienna, 1 car, a dog and 2 kids. And we've never, ever been dissatisfied in our life. Yeah. So very long answer.
Okay, so just, it's Dean, Ayesha, and Peter, so everyone knows who everyone is. So Peter Breggin at the end, and Dean Knight, Ayesha, Sherzai. Okay, so the first question is, it's 2019. Is Alice, when we talk about autism, the rates have changed in the last 60 years. When we talk about Alzheimer's, have I just not been aware of it? Has Alzheimer's and diabetes has gone way up, obesity has gone up? What is the difference in the prevalence, not the total number, but the prevalence, the percentage of people with Alzheimer's compared to 50 years ago? What is the difference?
Okay, it's significantly higher for 2 reasons. One is we became aware of Alzheimer's truly as a nation when in 1994, President Reagan actually announced that he had Alzheimer's. It wasn't that it didn't exist before. It just became much more, highlighted. The second thing is the prevalence grew for 2 reasons. Diseases that used to kill us, we're managing those, but they're causing other things secondarily. Diabetes is being managed, but it's causing the damage that leads to Alzheimer's. Hypertension is being managed, not well actually, but it's causing the dementia. In fact, one paper that just came out, we just spoke about it in our social media, that even mild elevated blood pressures on a regular basis at midlife increases your chance of Alzheimer's by 20%. So that's the disease part. We're managing chronic disease semi-well, but we're causing other things secondarily. And the second thing is we're getting older as a population, significantly older. Most of the people don't recognize how quickly we're aging, and that's a wonderful thing. But with that comes, if you're aging without any change in your perspective and your paradigm, you're aging poorly. And there's the answer. Doing anything poorly is not good. So we're aging poorly with chronic disease, with medication that just surface covers things, but doesn't do anything fundamental. Let me give you an example of high blood pressure. I know it sounds like I take everything long, but here, I'll be short, as much as I can. High blood pressure medicine. You have high blood pressure in your 40s. So they give you a blood pressure medication. What does the blood pressure medicine do? Nothing. It just opens the vessels artificially, and nothing with regards to what's going on underneath. The pathology that's accumulating because of the food and stress and everything else. So you've artificially maintained it open. In 6 months, because the damage continued, now you need 2 blood pressure medicines. In 3 years, now you need 3 medicines, then it's done. What have you done to reverse the underlying cause? Nothing. What can reverse the underlying cause? By now you should know the term, lifestyle. But when have we ever taught anybody in medical school to even say the words lifestyle, let alone teach lifestyle? Never. In fact, even in any population of doctors, they're so cynical to even bring it up, not because they don't believe in it, because they don't believe that we can make the change in the population. So we have to do it. Those are the factors.
Hi. That's the first time I've ever been late. But I mean, quite literally for anything like this. But then again, it's the first time I've been 81. So who knows? We don't have any kind of data. I don't disagree with anything. By the way, I loved their presentation so much, I bought your book. And I wanted to say that I learned something from your presentation about how to help my mother-in-law, who I actually invited to come live with us because I wanted her to know I really meant it. She's 94. And I've been afraid to challenge her short-term memory issues. She fell and had a concussion, and things just went down. So I'm going to challenge more and encourage her more. She's a very, very intelligent woman. But the other thing I found about it was that the love in the new family at first was very unaccustomed to her, that people were actually living together in a loving manner. That was their priority. And she has actually responded enormously to that. And the trauma that brought her to us, because she lived far away and she was not being treated well, that's why I said, come on here. The effect of just a therapeutic kind of intervention with her about the future, about hope, about the love that was still ahead, about that the dog was going to live at least another 7 or 8 years, and maybe more, and teasing her about getting a Yorkie, and reminding her just what our lives were about together and what a blessing it was for Ginger. And she pulled out of being in the depression on top of the concussion and the losses. So at 94, she's responding to the principles, I believe in, of how you help people, and I was just very pleased with that. But I was really off base in being afraid to play cards with her and challenge her. She always won at Jen, and I didn't see anything I could gain from playing her, because if I won, it didn't prove anything clearly, and if she won, it's going to be an embarrassment. And I told her that, and she says a good sense of humor, but I was a little afraid to challenge her. And I think that's a real gift already, just for me, from listening to and knowing you. We don't have any data, but there's been a huge increase in giving neurotoxins to everyone. And it's got to be playing a very significant role in Alzheimer's-like diseases. I don't know what its contribution is going to be to the specific. No one's looking at it, but we have data for every group of psychiatric drugs that they cause, in some people, a significant percentage, atrophy of the brain and dementia. And why wouldn't they? They're poisonous to the nervous system, to the brain, to the mitochondria, to the cell membranes. I mean, they're just not good for people. Okay. And I'm supposed to look forward. That's a good idea anyway. So I think we need to look a lot more at that, because we have so many studies of brain injury in children who are getting the stimulant drugs, that it was originally used as a claim that ADHD came from brain damage. And an ADHD isn't even a disorder that you can define. It's meaningless. It's just a bunch of things that irritate teachers. Every single line is something that irritates teachers. Wasn't even intended to have the parents give the drugs. It was aimed at recruiting the teachers to control the kids with a drug that kills spontaneity. So even there, I was at the consensus conference. I was the scientific expert on adverse effects at the ADHD consensus conference, and they produced slide after slide to show that ADHD was a brain disorder, and we challenged them and said, do you have a single one where they weren't on drugs? Oh, no, we don't have any. It's very hard to find anybody who isn't on drugs, which is a lie in terms of all the children that are getting diagnosed ADHD. So in regard to the antipsychotic drugs in Great Britain, some friends of mine.
Peter, let me step in. I'm gonna try to go through 50 questions and give you an opportunity to be very specific. And so, although it would be great to get lots of information, I would like to try to ask very quick, sharp questions for our non-scientific audience, which is 98% of them. Okay, so let me just go through here. Okay, so just to be clear, if diabetes has gone from very low to close to 10%, and obesity's gone from under 10% in the 1960s to 40%, what was Alzheimer's as a percentage of, I don't know, people over 65 in the 60s versus today? Is there any information?
We don't know, because it wasn't being diagnosed. It was not being diagnosed. First of all, it wasn't being diagnosed as Alzheimer's, let alone as far as percentage is concerned.
Do you guys have a guess or an estimate, a gut feeling? Like, is it like obesity and these other things, that it's clearly become a much bigger problem, or is this clearly, it's one thing to say the population's aging, or are we saying it's never been like this, we have a crisis, it's gone up from a tiny thing to a big, like, is this, like diabetes and obesity, something that's gone up dramatically, or has it always been like this?
No, so that's a separate question. It has gone up dramatically. It is a crisis. It's a crisis because of the numbers and the rate of numbers going up. Remember that when we start collecting data really accurately from the 1980s till now, it has gone exponentially up, more than 123% up. So there's some data there. And as far as the other problem is cost, the cost to the healthcare system was non-existent 50 years ago when it came to Alzheimer's, but it's now 3 times heart disease, or 4 times heart disease, the cost of heart disease. So that's an indirect measure of how it has changed.
I'd like to add something to that. So yes, it's definitely gone up, but I think the definition has also changed. There was a time when, people, elderly, would have cognitive impairment, but it was synonymous with getting old. Oh, yeah, grandma or grandpa forgot, what they ate for breakfast, and that was considered normal. And that happens now as well, but it's not supposed to be normal. It's not supposed to be normal for somebody in their 60s to have significant cognitive impairment. And I think with more information, with examples like President Reagan, and having movies and documentaries about what brain health is and what dementia is, I think people are getting more aware. And even that awareness is not ubiquitous in our society. There are a lot of communities, and especially the Hispanic community, who don't have real access to health care, and they consider taking care of their elderly at home. If the symptoms of cognitive impairment arises, they're never taken to a hospital or a clinic. So I think that's what is causing a little bit of confusion as far as numbers are concerned. So yes, we are getting older. We're not living a healthy lifestyle, and the definition of dementia has changed significantly.
So it seems like when it comes to obesity and diabetes type 2, it is so crystal clear that your lifestyle can make a difference. I'm just a regular person who reads whatever I read in the papers, and I think I'm reading a lot of people saying Alzheimer's is something that you really can't prevent. And then I saw your presentation, I was like, that's fantastic. You're saying that your lifestyle could affect it, but maybe you guys are wrong. If all these other people are saying that there's nothing you could do, why did you come to the conclusion that it can be prevented? And if it's true what you're saying, why is so many mainstream doctors and media saying that Alzheimer's is not something we have control over?
They're wrong. No more than that? Okay. So, as you saw, we presented data and papers from not just some one-off, study that looked at small little population observation. We're talking about Columbia University. We're talking about Framingham Health Study. We're talking about Adventist Health Study. We're talking about California Teacher Study. We're talking about the Rush Study. We're talking about the Chicago Study. These are the biggest studies in the country. And those are not just one-off little studies. These are major studies, and many, many more that have shown that lifestyle actually affects progression to Alzheimer's. So the data is there. Why aren't people talking about it? Is because who would be talking about that? I mean, think about it. It has to be somebody that is interested in lifestyle intervention. In a private clinic setting, you don't have the time to do lifestyle intervention because the rate of patient care. In academic setting, if you're at all interested in doing anything beyond pills and surgery, it's in the academic esoteric realm, right? Molecular stuff. So who would be talking about lifestyle? That's already been shown. Nobody, except some crazy people that want to do something outside. So there's no doubt that there's evidence that lifestyle affects outcome. Absolutely no doubt. But why it's not being spread out is because the venue of spreading it does not exist in the healthcare system. There has to be a venue. If you want to show a movie and you go to a jungle and there's no movie theaters, and then you can't ask, why aren't there movies in this place? Could it be that the movies are false? That was a good analogy.
I like that.
Just came up with it.
There's no doubt, though, that also to add to this, and I'm wondering if it's getting any consideration at all, that the elderly population is swimming in psychoactive substances in a way it never has. And in fact, it's one of the largest consumers. So if you think about people with the most vulnerable brains in our community are among the largest percentage-wise consumers. It would probably be hard in any study of Alzheimer's patients, I would imagine, to find too many that weren't on some psychoactive substance. And is anybody looking at it? I know in psychiatry, nobody's looking at it that I know of, and a few people, maybe in Great Britain, but is anybody putting that into the equation? It's a pretty obvious elephant in the room.
So,
Yeah, President.
Short answer is no. It's really not given credence and the attention that it needs in the bigger realm of things, as is lifestyle.
Right.
And I think it's all driven by the fact that, again, coming back to how doctors are trained, we're basically trained in sick care. We just kind of wait with our arms crossed, wearing our white coats in the hospital, waiting for people to get sick, and we see them, when there's really not much that one can do. And what we're talking about, and that's public health. True public health is, catch them before they even manifest that disease. Catch them when they're on that journey towards getting sick. And I think that's true healthcare. So
let me go on to the next thing. So then I guess if you are making a case, if you've written a whole book on lifestyle, and we could ask more about that after, about the specifics, although you did present it in detail. But if you're saying that lifestyle is what you believe is the solution, then why, right now as we speak, are there drugs on the market to treat Alzheimer's? In other words, again, how does this all work? Why would a pharmaceutical company be selling a drug if you're saying it doesn't work? And why wouldn't the media and the politicians and the government agencies be telling everyone, don't take the drug, instead do lifestyle? There's a book, it proves it works. And why isn't the media, why isn't the New York Times writing about it? Like, why, if this is true, isn't all forces of government, media, university, science telling everyone the truth? And instead, and why is there drugs being sold if they don't work? So how is why are we, the Real Truth About Health conference, are we announcing that there's a way to deal with this? What about all these other parts of society that we count on to get this straight? What's going on?
And I'm going to even make it more complicated. There's no conspiracy. There's a flaw in the machine. There are times where there's a flaw in the machine. When the machine is focused to a hammer, everything is a nail. To a disease-based system, everything is a disease or nothing else. And it's so incredibly true here. I'm going to repeat what I just said earlier. I don't want you to this is incredibly important. Although there's a little bit of shift now, because they're seeing what are the mechanisms of interface between people and pre-disease? I mean, we're talking about pre-disease, right? Prevention. Medical students do not deal with pre-disease, only disease. Doctors don't deal with pre-disease, only disease. The insurance companies do not fund for pre-disease. only disease. Because we are so inefficient in treating disease that by itself it's already several $1 trillion. Now you're going to add pre-disease to this? So, and the pharmaceutical companies, there's no evil there. They're going to make money from disease because it's identified, it's a motivator. You're not motivated when you're 30 years old to avoid Alzheimer's. You're motivated when you develop Alzheimer's. And not, by the way, none of the pharmaceutical companies say that their drugs work to stop or slow down the disease. So there's no controversy here. Aricept by Pfizer. Pfizer says our drug, very accurately, appropriately, our drug is a disease symptomatic treatment, the drug. What does that mean? It does not slow or stop the disease. No controversy. They're being accurate. And they even did the next study that showed that it only affects the disease for 4 years. After 4 years, the person ends up the same place otherwise where the curve would have been. So they're not evil. Nobody's doing anything controversially or behind the scene. The machine is focused around when the process comes to the surface. We're talking about pre-surface. So is it more, the question to be asked is it more cost effective to focus on pre-disease? Not yet. It wasn't yet. Why? Because we didn't have the tools to identify pre-disease accurately enough instead of treating 300 million people. So if somebody is a pre-disease suspect for Alzheimer's, and it's very accurate, and we reduce it to 1 million people, and I'll tell you why, and why people actually have listened to our book. We have had 3 insurance companies come to us, national insurance companies, and others as well. But we even told them, until you can become so specific in your diagnosis, pre-diagnosis, where you could accurately identify the 1 million people that if you, at age 40, this 1 million people, 90% of them will go to the Alzheimer's, then it's cost effective. But if you say everybody's at risk, which I did today, the insurance companies don't have the impetus to spend on all 300 million people. So that's why we're going to the source itself, the population. The insurance companies are not evil. The pharmaceuticals are not evil. The system is set financially to hit the target. And when the target is not known, what are you going to hit? Am I making sense? I mean, so I'm talking about a 40-year-old that doesn't even care that he gets drunk and not blacks out, which affects their brain. That in 20 years, your chance of going to Alzheimer's goes higher by several months. Do you think they care? That target is not reachable. So that's the system. That's the flaw in the system. So actually, thank you for pushing that because that's...
I don't know. If there's no evil out there, I don't know who the hell's been trying to beat me up and take away my medical license. And I was going to say, if there's no evil out there, I don't know who's been trying to beat the hell out of me for all these years, go after my medical license, keep me from speaking at universities, cut me off from the media.
But those guys are evil.
I just don't know who's... I'm going to take a minute on this. No, because I think partly, and I love what you're doing, but I think partly what you're describing as this intellectual problem is the direct result of evil. And I could go into it at some depth. I haven't gotten in much say yet. Can I talk about that for 5 minutes, sir? Yeah. All right. All right. As I mentioned earlier, I was the chief expert for all of the Prozac suits. And about 150 or 60 of them against Eli Lilly. Within a period of time, and I was chosen by a consortium of lawyers. All right, the first lawyer was removed that I was working with because after I quit him because I didn't think he was behaving ethically. The second lawyer, who was a really good guy, died. And then the third lawyer, who took over for the consortium, immediately went to work building a consortium with Eli Lilly. So here we have a consortium of lawyers who are supposed to be bringing all these suits. I'm the single scientific expert to make it easier for them. And they go to court and they fix the entire process. And this is now known factually. So I noticed that I don't get, this new lawyer doesn't call me, trial's coming up, doesn't tell me what's going on. Usually for a petty trial, I'd spend a half a day reviewing the notes that we're going to, what we're going to go over in the trial. My wife, very early on, Ginger, says, honey, this is fixed. This entire thing is fixed. I don't believe that, honey. I get to the trial, and I'm not in the same hotel with the lawyer that's supposed to be on my side. We're working together. It's a mass murder. It's related closely to Prozac, very closely. And they're not in the same building with me. They're in the same building with Eli Lilly's lawyers across town. My testimony gets delayed not for reasons these guys wanted. And so I have a day off. So I insist on going to the law house, the offices of the lawyers who are supposed to be preparing me. I find 40 depositions I haven't been told about. I find a whole outline of the case by Lilly, which has been distributed, that I haven't been told about. And up to the last minute, these lawyers don't interview me and prepare me for my testimony. So if you watch the video, I'm asking and answering my questions. And I actually confronted him about this at the table of these guys. I said, what are you doing? So they asked me, we'll ask you a question. These are the lawyers I'm supposed to be working with. So when the trial is over, I feel like quitting and just giving up in this work. And then I find out that the judge has discovered the thing was fixed. He didn't know how far back the fix went, and the trial was overturned. There is evil. Now, at the same time, and I don't think I mentioned this to you, during the depositions that I was going through, I don't know what drug company might have done it, but we all got sick in my house. And we were going to doctors, and then finally a plumber who happened to go downstairs for something said, do you know what's going on in your basement? Do you know the chimney for your furnace and the chimney for your hot water heater are removed and hidden in a corner? And we had been going to doctors. The kid, my wife and my daughter were much sicker than me because my office was above ground and theirs was above the basement. Now, I could go on and on about the cheating and lying that goes on inside, and I'll name, I won't bother naming them. I've written about it in my books. I've lectured about it. When these companies find out that their drugs are hurting somebody, they build a committee to PR it and to reject it. You try to get an article published that's critical, and they show it to the drug companies, and on and on. If somebody's a critic, they offer them $100,000 a year to do any research they want. That happened to two of the people on my board. They didn't take the money. And at one point, I got offered $1 million through my attorney, but he wouldn't tell me from who. It goes on and on. Read the Bible. We live in a corrupt world. And I really like you guys. But I really do like you. Your work is great, and I don't want to take a thing away from it. But I've been inside these companies. I've been in product liability suits against Upjohn, against Johnson & Johnson, against Eli Lilly. And all you find is absolutely ignoring deaths from these drugs and everything.
I think
stop.
we were talking in different...
You want me to stop, I'll stop.
No. I think we were talking about different contexts. Is there evil in the world? Obviously. I was trying to focus on a mechanistic process that's enough for all this machine to not work. But you brought up another side. Yeah, they're evil. But I wanted to focus on the mechanistic. The mechanistics...
I don't think that's what drives it. What drives it is human avarice, which follows the money. The drug companies have so much money. They've got a quarter, last I read, of our budget. They are filthy rich. They build buildings in their own name on the campuses. They have professors in their own names. I don't think that we should just look at this and say it's the mechanism.
No, nobody's saying it's just the mechanism. No, we all understand the problem from evil. We know that there's evil. We know that how from 2010, now you're getting me all started.
I'd like to, because I think it's more real.
I'll let you. No, there's reality on both sides. I think it's good to be a comprehensive in our approach. And I'm not at all negating what you're saying. I completely concur.
Okay, all right.
And when it comes to lifestyle and research on food, 2010 there was a consensus gathering in Mexico as far as meat and dairy and egg and all these industries, and the fact that the decline in sales. And after that, all of a sudden you're getting 3 or 4 scientists getting paid big time doing meta-analysis that are coming out with results that you couldn't think that would come out of the data that goes into it. Remember, meta-analysis can be manipulated. Depending on what variables you put in is the variables you come out.
Yeah.
And if you do a heart study and you leave out cholesterol as one of the confounders, what are you going to get as an outcome? Yeah. So I know about all that evil. I agree with you fully, and I'm 100% sure that that's a big, big driver. But the other driver is also a factor, because majority of doctors are not evil. So I'm talking about from a physician. So why aren't the physicians in this game? Why aren't they jumping into this game? Not because they're evil, because they've been put into a machine that doesn't allow them to look outside of their, what do they call it with their horses? Blinders. Well, there's a more technical term to that, but blinders. They can't look outside of their blinders. They don't even have time to look outside. Out of thousands and thousands and thousands of doctors, millions, why isn't there a handful of the Clappers, a handful of Esselsteins and others that speak out and have done the studies, and yet others don't? Why? Not because they're evil.
Because of the price you pay, because how badly they get beat up. Campbell himself.
No, I don't agree with that. No, I don't want it to be controversial. I don't think the doctors are if 1 million doctors are afraid of getting beat up. 1 million doctors are so overburdened. I'm a doctor. They're so overburdened that they just want to get the next thing done. Not because it's the money. You get stuck in a machine. And that's why the highest depression rates are among doctors. I want us to clarify here, because I really want to be part of a panel where the outcome is something useful, not just anger.
Wait a minute, are you saying what I'm saying is not useful?
100% useful.
No, I mean, I'm serious, because I think the heart of the argument is here, because I know what happens to a young psychiatrist if they don't give drugs in a clinic. They get fired, and their careers get ruined. Young psychiatrists, they have no other way to make a living.
I'm a neurologist. I was a neurologist at Georgetown, NIH, Cedars-Sinai, UCSD here. I have given less Aricept and Namenda, which is the drug that I'm supposed to give, than any geriatrician.
I think you're a good guy.
No, wait. We slipped here. Why have I not gotten punished? That's true.
Well,
I'm done. I'm good.
You just became his favorite person.
I have part of the answer, because you don't call what's being done. That stops the people who are in that area where they could make a change. One of my closest friends, a neurologist with John Friedberg, he stood up as a resident in neurology in California and criticized shock treatment. He even got a paper published on it in the APA journal, I don't know how, and they fired him from his residency.
Yeah,
he
that's
could only
understandable.
find one other residency to go to, and that was another dear friend of mine who had the guts to take on the lobotomists up in Oregon. I think that there is a real issue here.
I agree.
Yeah.
I agree.
No, it's basically like if you don't really fit in the box, you should get out of the box.
Exactly, or we'll
And-
throw
and-
you out.
Right, and the resources or yeah, the options are not given for people, for doctors to go to the road less traveled that we were talking about. I remember coming out of fellowship from, well, I shouldn't name names. I'm not going to name names. But I remember coming out of fellowship after research and after, spending a lot of time in the ICU and in the stroke unit. And I remember telling one of my mentors that I was going to go into lifestyle because I was a big believer of prevention rather than this, silly treatment. It's not even treatment. It's just slapping some people with some aspirin and statins. And I recall the day, and I went with him with a lot of hope because I just idolized the man. He has his names all over the books, and he's and he told me, he said that's career suicide. Nobody's ever going to support you. You'll never get a grant.
Yeah.
That's a field that is essentially not important at all. And I remember that feeling of my heart just sinking because I knew that I was I was putting myself in an area, in a gray area where I didn't know whether I was going to be a successful physician or a scientist. But I'm glad I have a partner, and we both made that decision together, and it was the best decision ever.
Yeah. It's wonderful. Pam Popper, whom all of you know, you've heard Pam, very dear friend of mine. I nearly freaked out when she put my picture up at the start of her thing. Pam Popper, when she began to speak, and this is on a fairly low level at the time, when she began to talk about nutrition, they went after her in Ohio with all their might, and they called her up on a carpet before the nutrition committee of the state. When she finally confronted them, they threatened to put her in jail for contempt. And then they raided another physician's, I'm seeing nodding heads who know the story, they raided, with guns, somebody else's office to get data on who was doing nutrition outside the box. So God bless Pam, she's a fighter, and she went ahead and she got politicians on her side, and she disbanded the state's nutrition committee. But so once you face against money, and if we don't face this, we'll get nowhere. If you don't face that there's these huge money forces out there. Campbell's been through the same thing, not quite as severe as me, or maybe not as much as Pam, but this is the greatest man that's ever been in the history of nutrition, and he's not allowed to see students. He has to have an online program. Yeah. I mean, and he's written a book about it now. What's his new book called? Oh gosh, it's Whole. His new book is Whole, W-H-O-L-E. And he gives some of the story of this, of what he's been through. And he started within the institutions. I started out, and they spotted me and really went after me early, and they didn't kill me. And that's changed a lot of the what the landscape looks like. There's a lot of other people doing what I'm doing now.
I completely agree with you.
Okay,
I mean, the
then
things
I'm
that
gonna
you
rest.
and Dr. Colin Campbell and others went through, because, pioneers in the field, the iconoclasts at the beginning, they actually went through quite a bit. But things are changing, and especially for, my generation of physicians, I'll speak for myself. I mean, we have a lifestyle fellowship at Loma Linda University.
Yeah, I think that's great.
And we, with the power of media, social media, I mean, there was a time when we looked down on Facebook and Twitter, and we told our nieces and nephews to stay away from it. But I think it's a revolution, because you connect with individuals and physicians across the globe who have the same belief systems, and now we actually have a platform where we can speak, we can talk about prevention of disease, and it's been an incredible journey.
I think it's wonderful.
With what you don't know, Ayesha, you were just audited by the IRS.
That happened to Pam.
I'm joking. I was just
They
joking.
were-
Let me go on. I have
harassment
a
of
question
Pam.
to ask.
Yes. Listen.
So, Peter, there's something I want to ask that I almost feel not sure if I could say this out loud, but let me ask you, since you seem open to this. If we ask the audience, what do you think about the donut industry? Everyone would say, they're just trying to make money. I don't feel good about it. If I said, what about the soda industry? 100%, everyone's in. If I said, what about the pepperoni and salami business? Total agreement. Fossil fuels, total agreement. What about the, Monsanto and the chemicals? We could get everyone to agree. But then there's this one question that follows. It's like everything else, but yet we completely lose the audience, and everyone says, what are you talking about? And that question is, and I'm not sure you're supposed to say this out loud, but is it possible that pharmaceutical drugs don't really work, that the negatives of them outweigh the benefit, to the point that, with the exception of, let's take antibiotics off the table, but aside from antibiotics, and I assume there's amazing drugs to, for certain things, but for so many of the drugs out there, is it possible that every doctor who's smart and intelligent and honest is being misled by clinical trials, medical journals, and studies that are not accurate, and the entire, the whole business of pharmaceutical drugs is mostly based on clinical trials that were tampered with to the point that they're not accurate? Is it possible that most drugs are actually worse than the benefit? Or help me how to think about this. Are pharmaceutical drugs mostly like donuts? I mean, help me.
Well, I don't think there's any question about it. I don't think there's any question about this at all. I mean, there's so many ways to look at it. Why do we give a certain amount of drug for blood pressure? Because a committee got together, made up of people mostly endowed by the pharmaceutical industry to keep rising the levels of what is hypertension or what is blood sugar. All of these things that bring in more and more drugs throughout. In every place you look, they are under the sway of the dollar. I couldn't believe it when I first started looking into what was going on in psychiatry. Everybody, not everybody, maybe 80% of the panel members of the committees that advise the FDA are given letters exonerating them from their conflicts of interest because they have them and they don't want to get sued. Otherwise, they wouldn't be on the panels. I just couldn't believe that. Everywhere you look at the sliding door between who gets hired by the FDA up top, which are the pharmaceutical people, and then the people at the top of the FDA retire and they go out and work for the pharmaceutical companies. You can't look anywhere where this corruption hasn't taken place. And the dollar is just almighty. When psychotherapy started to really take off and women started entering the field, it happened because the insurance companies stopped forcing non-medical people to have medical supervision. So you could be a social worker, you could get a certain amount of money. So, who would start in California? And what California woman isn't going to want to go to another woman rather than to some male guy with all these things on his wall who's even more objectifying of her than her poor husband is? So the system started to collapse. They weren't getting enough members into APA, Psychiatric Association, because they were going to see women more and more throughout the country. APA, I document this in Toxic Psychiatry in the minutes, said, what are we going to do? They said, we're going to go and collaborate with the drug companies. And with that, psychiatrists stopped doing psychotherapy. They stopped teaching it. It wasn't going to be the moneymaker. There have been decent psychotherapy is hardly taught at all. In some places, not at all. I mean, the whole system. I sent a letter to the New York Times at one point because they asked, why did George Bush, why was he allowed to take Halcyon? Because he'd gone to see the premier of Japan and he'd gotten sick. He'd vomited at the table. It was the elder, dignified George Bush. And so and why was it outlawed in Great Britain? And they didn't even know that the drug causes paranoia. Our president's taking Halcyon on his flight over for sleep, and it causes paranoia. He's going to go and visit in Japan. So I wrote them a letter, and I sent them a picture, and I said, here's the Upjohn Company, the maker, giving $1 million check to the American Psychiatric Association with no holds barred at all. They can do whatever they want with it. So the medical director writes back to the APA, and this is pertinent to your question, there are no conspiracies. The APA medical director writes back and says, Dr. Breggin doesn't understand. We have an ethical partnership with the drug companies. That's in writing. About conspiracy, people plan. NFL owners plan. Business people plan. Everybody who has power plans to consolidate, to increase their power. And when you have this huge power, this medical industrial complex, like Dwight Eisenhower's military industrial complex, you plan. You plan with the other presidents. You plan with everybody you can get your hands on. And maybe it's not conspiracy, it's planning, and it's covert planning. Really. I don't mean to be so feverish about this, but I mean, I live in this world. Thank you, God, for being alive.
So just to follow up, because
Oh, and the trials, they all suck in my field. They did a 3-week trial to get an amphetamine. Oh, I need that. An amphetamine approved to give it to children. 3 weeks. I mean, it's appalling. Now, the average doctor, he doesn't know anything about this, but the average human being doesn't know anything about what's going on in the world. And the average doctor, I don't know if they're any better. I've always been looking for better people somewhere. I don't know if they're any better than other people. But the information they're getting is not just because of a system, it's a huge organization of money.
So I know now that what this panel is about, so we'll start going that way then. So
I'll stop. I wasn't
No,
going that way
I love
until
hearing
you
this.
said no evil, no conspiracies. What world am I in?
context. You're 81 years old. You recognize context. No, I worked with Tommy Thompson. You remember Tommy Thompson? He was the Secretary of Health and Human Services. I was the one that actually created the whole healthcare system of Afghanistan in 2001 and 2002. And I worked with Julie Gerberding. So he's right in the sense that guess where they're working now? Every FDA director, CDC director, HHS director, after they leave, guess where they get jobs? Yeah. So I understand the evil, but I just didn't want to go in that direction. It's just
Well, thank you,
too
Dean.
evil.
I really appreciate you're not just, dissing me.
No,
Not
of
at
course
all.
not. Of course not.
Not at all.
Speaking to his statement that why is everybody else not doing it? It's a machine. Part of it is the evil. I'll leave that to him. He's good with the evil. Part of it is the machine. Aspirin, biggest drug out there. What's the number needed to treat? NNT. Meaning that how many people do you have to give aspirin where one person avoids a first stroke or one person avoids a first heart attack? More than 1,600 people. Yeah. So, and then another way they manipulate. Oh, you got me started now.
Good. This is, are you glad?
We're gonna get sued. We're gonna get sued together. Yeah.
This is the
There's-
first time
in
I ever had a
science,
good
there
effect
is-
on a panel.
In science, there is the. Well, real truth is vast and wide. You can talk about systematic, conspiracy, a whole range of things. I mean, I could talk about the kale, and there would be real truth in kale. So, but in science, you do a kind of thing called absolute risk reduction and relative risk reduction. And in cholesterol, they would say there's a 33% risk reduction in using this drug. What they were doing was they were doing relative risk reduction and not absolute risk reduction. The absolute risk reduction was without the drug, you had 3% chance, and with the drug, it would go down to 2%, right? That's the absolute risk reduction of
Important.
1%. But when you do relative risk reduction, they counted it as 33%. So that's how they reported it.
So important.
So there's a lot of manipulation. Yeah.
So I would like to clarify one thing. I would like very much for this conference to be credible. I don't want people to say, oh, it's a UFO conference, they're a bunch of... So this isn't the anti-conference. I'm not against saying the alternative is good and the mainstream is bad. I just want to understand one thing. I am crystal clear that the candy industry wants to sell me candy and doesn't care about my health. I'm crystal clear that the soda industry, this breakfast cereal industry, the salt industry, the high fructose corn syrup, they want to make sales, they don't care about me. I want to understand one thing. I am trying, and I don't want, and it's okay to say I'm way out, I don't understand this. I don't know how many pharmaceutical drugs are on the market. I'd like to know how many are on the market and how many are actually more beneficial than harmful. In other words, if it's true that all these doctors are getting their education from clinical trials and medical journals and med school, and you're saying that clinical trials are a broken system, and when the study that the doctor uses was not a real study, it was a manipulated study, then no matter how smart, honest, and good intentioned that doctor is, he had bad information. So what I want to understand is, are the pharmaceutical drugs that we all take and all believe in and are all told by the doctor, is it all based on data that was fudged, that was manipulated, that was tricked? What is the reality of how we should think about the pharmaceutical drug? Let's take antibiotics off the table and think about all the others. How should we be thinking about when we're prescribed a pharmaceutical drug?
Well, in psychiatry, I'll be brief. In psychiatry, it's all fudged. Every last trial. They are too short, first of all, 6 or 7 weeks, so it's meaningless. So they're all fudged. They're all farmed out to doctors who the companies hire, and the doctors are going to deliver, and it's pretty easy to deliver. The protocols are written by the drug companies, and they're written by the marketing department, really, in many ways, because they're figuring out how to make the trial come out so you can market the drug. I mean, it's not very complicated. The entire process. If a doctor wants to publish an article saying the drug didn't work, he's prohibited from doing it if he's been a part of the trial. The so-called scientist, who's the principal investigator, does not himself evaluate the data. The data is evaluated at the drug company, and then when the article comes out, in a large percentage of cases, and if you Google this, you'll get articles looking at the percentages, but a big proportion are ghost-written. Doctors are paid to put their names on an article written inside the drug company. And that is the status quo within the area that I know so horribly well. It is none of it reliable, and that's the only way you can make believe that a neurotoxin is good for people with emotional problems. Did I answer? That's just my feel. I don't know the other ones really well.
In my field, I agree with you. When it comes to psychotropic drugs or medication for mood and psychiatry, there's a lot of gray area, and I think you know it better than anyone else. In my field, I deal with a lot of stroke patients. So stroke, for some of you that don't know what stroke is, usually a clot blocks the path of blood in one of the arteries in the brain, and an area of the brain doesn't get oxygen and nutrition, and it dies. It's an emergency. People come in, and we get paged, we're running around trying to make sure that we get to that person as soon as possible, because we have this one drug called TPA, which is a clot-busting medication. And that person can get that clot-busting medication between 3 to 4.5 hours. Anything beyond that, then they won't be eligible for it, because it actually causes more harm than cure. At times, when the person comes in within that time period and they get TPA, their symptoms are completely reversed. They actually gain function of their arm and their leg. And if they go past that hour, they go to a neurointerventional radiologist, and what they do is they puncture your groin, they go into your artery, they get into the artery in the brain, they identify the clot, and then they pull it out. Yes, it's very invasive. Yes, it's very expensive, but it does save lives. Let me give you another example. When in the emergency somebody comes in and they have an acute bleed in their brain. Their blood pressure was so high, it was, say, for example, 220/110. The artery that was already riddled with cholesterol plaques, because they didn't really care about that hamburger they were eating over and over again for the past 10 years, caused it. And so that artery ruptures, and in the emergency room, we run to the patient to lower down their blood pressure, because it actually controls the size of the bleed. They can die. The mortality related to hemorrhagic strokes or bleed in the brain is very, very high. But when you reduce their blood pressure right away, when you manage their glucose levels, which is usually raging high, and when you make sure that you get diagnostics to control the size of the hemorrhage by giving them hypertonic saline, which is like lots of sodium, you actually shrink the size of the bleed. So those are medications that actually mean life and death. They work. And they do work. They do work. Are they necessary? Absolutely. Have they helped save people? Absolutely. I do this every single day in the emergency room. But is that the answer for everything else? Absolutely not. Cholesterol medication. When somebody has a stroke, we put them on a very high dose of cholesterol medication because they come in with an LDL of 200. Obviously, I want to lower it as soon as possible, because I know that within the next 48 hours, they'll have another stroke and they'll die. And so for me, looking at that entire person, their family, their children, their whole story, my mission is to make sure that they live. And I use whatever I can to make them live. And it does work. But at the same time, even though they can't talk, they have a tube in their mouth and they say, when you get better, I'm going to talk to you about diet and exercise, okay? See you later. And I understand that that's not the long-term answer for making sure that people, live a healthy lifestyle, but they do work. They do work.
In my field.
May I ask you a question? By the way, of course, I agree with you about emergency medicine. I think that that's the one place most of us can agree on is the emergency life-saving medicine. My impression of the cholesterol studies and the 200, for example, somebody having a 200, and maybe there's new data, but when I looked at it and when a friend of mine, Tom Moore, wrote a book on it years ago, it was all loaded for people with very pathological cholesterols of like 500. And when somebody was trying to tell me to take the prescription fish oil, I looked at some of the data, and first of all, it had a lot of adverse effects. I was really surprised at that, but it was at large doses that were under the pharmaceutical industry. And again, it seemed to be skewed to people who almost never get there, which are these large numbers. So I don't know if it's true that a 200 cholesterol is going to vastly increase anybody's risk of anything. I don't know if you know the data. I certainly don't mean to put you on the spot.
Well, no, we do actually have very clear data that high cholesterol increases your chance for Alzheimer's disease, and in stroke specifically.
No, I meant stroke, yeah. I was thinking more, not of Alzheimer's, but of the
cardiovascular disease. I think there is data, and it's been repeated and it's been validated in multiple studies, and there have even been some clinical trials that have used statins in the setting of an acute stroke by lowering cholesterol levels, bad cholesterol levels, drastically within the first few days, and then continuing it for a couple of weeks actually lowers chances of mortality related to stroke. There was a Sparkle trial which looked at the pleiotropic effect or the anti-inflammatory effects of statins during acute stroke, and it looks like it actually shrinks the size of the penumbra, which is the area of the brain that is shocked after a stroke. It definitely decreases the size. But again, I'll preface it by saying that is not the long-term answer.
Right.
More patients actually get out of our clinic without medication than they actually came in. We said lifestyle is the long-term answer, but if you're so sick where we don't really have a lot of tools to do, I want to make sure you live, and I'm going to use whatever I have.
For my disease, none of the drugs work for what people think they work for. Aricept, Exelon, Namenda, they don't slow the disease or stop the disease. There's no question. Not even the pharmaceutical companies say that. Yet, everybody that comes to me from a general practitioner says, the doctor gave me this to slow the disease. It doesn't. So if it doesn't slow the disease, why do we keep going in the same direction? Yet we showed you data after data after data that lifestyle significantly reduces it. Now, where is the problem again? When it comes to the pharmaceutical, in this case, they want to do research and raise money from NIH and other directions on a molecular basis because it's easier to target. And that's why we keep missing the target. That's where the flaw or evil, whatever we want to call it. I'll pick whatever word. And then the mechanism is that we just don't want to focus on lifestyle. So where does the responsibility fall? I agree with you. A greedy system creates a system.
Talking to the microphone.
A greedy system is a system that will do whatever, true or false, and usually it's more expedient to do the false, easy thing to make money. That's true. I'm not arguing with that at all. A system that is based on medicine is going to push whatever tool it has to make money. That means the doctors are part of this, not because they're evil, because otherwise they're left with, well, why am I getting paid? So they're going to give you medicine. And even if medicines that don't have any significant benefit, and hospitals and all of these systems. And the research machine that's only interested in clinical trials that last 5 years, focus on a molecule, they get their grants, and at the end, even if there's a minuscule change, then they'll take it. Because the more complex lifestyle is going to take billions of dollars to do research. So at all steps, there seems to be a flaw. So I agree with you and myself.
So, before I move on, I just want to take one more try to, and it's okay if no one knows this answer. Taking out emergency medicine, taking out antibiotics. If clinical trials are not accurate, doesn't that mean that every doctor, no matter how smart, honest, credentialed, and fantastic they are, and honest, if someone is saying clearly that the system of clinical trials is a broken system, and this is how people decide what medicines to prescribe, doesn't that mean that we have to be very uncomfortable with all the medical recommendations? Like, I mean, I'm just trying to understand, what's the basis when the doctor says to me, take these drugs, if he's basing it on a clinical trial? If you're saying the clinical trials are trustworthy, then that all makes sense. But if you're saying we have a clinical trial system where they can do 10 trials, kick out the 7 they don't like, keep the 3 they want, doesn't that mean that every single time someone's given a drug, forget about emergency medicine, forget about antibiotics, doesn't that mean that he's making a recommendation to me based on very flawed information? Help me how to think about this.
I've answered, so go ahead.
We are always making flawed and partial decisions throughout history. When we first started with the first set of drugs, they were incredibly blunt drugs, bromide, blunt drugs, and that was the best we had. The problem was not the drug; it did its job. The problem was with explaining how much good it's doing and how much bad it's doing, and people just assumed since it was coming from a doctor that it did more good than bad. That wasn't always true. So we can't just lump everything into one category. There were drugs that were a little more effective than harmful, some that was less. And we became better and better and better. That's one problem. And now with cancer, we're actually going completely different paradigm now. We're using targeted ligand or targeted approach, antibody-directed approaches to cancer, which is very different than 5 years ago. We were just talking to an oncologist on that plane. He's saying that from 2 years ago, I'm practicing completely different than now, because it's completely targeted approach now. And in 5 years, it will be so much more different. Up to now, we've been giving poisons to people and hoping the cells that reproduce faster would consume poisons more, so they would die at faster rate than your regular cells. We all knew this, but that was all we had, and we took it. And there was different levels of utility. Some drugs were worse, some drugs were better, some pharmaceutical companies lied, some didn't and exaggerated. So the whole spectrum, there's no one thing. And we're evolving. The next level will be more targeted, more precise. And that's the way it is. And there will be still lying, there will still be cheating, there will still be stealing. But I just want to kind of paint the picture to be a little more broad than, the one element that we're always missing. The other element is research. You could be hitting a target 50 times out of 50 times. But if the target is here and it's supposed to be there, you're hitting the wrong target. That's what we're doing a lot of times, not all the time, a lot of times in pharmaceuticals and in research.
Okay.
We can stop. He got all the claps because he created controversy.
So today, Ayesha, you made recommendations on things people can do to be preventative in dealing with Alzheimer's. And you said something that every single whole food plant-based expert says, except for one. And what you said is eat a whole food plant-based diet of fruits, vegetables, whole grains, beans, nuts, seeds. Very good advice. Everyone says it. Every single whole food plant-based, except one. So Brian Clement of the Hippocrates Health Institute and Anna Marie Clement say, look, we've been doing live blood cell analysis for 25 years. We've been dealing with sick people. And the one thing we keep seeing under the microscope is, we hate to say this, we know it's upsetting, but fruit sugar, acts like sugar, and it feeds yeast, mold, fungus, and cancers. And even though it's the last thing anyone wants to hear, that fruit's been hybridized to be sweeter than it would be in nature, and somehow, as much as it's natural, fruit sugar is sugar and feeds diabetes. And he's saying that diabetes is, he calls Alzheimer's type 3 diabetes. So the question is, if you're giving the best advice on preventing diabetes, do you agree that avoiding fruit sugar or minimizing it to, he says, in healthy people, 15% of your diet by weight, but really he's saying like a piece a day and less if you have a sickness. Do you agree with him that fruit sugar would be better to be left out of the diet, and if you're dealing with dementia, even eliminate completely?
I would have to make myself familiar with Dr. Clemens's research and findings. But just as a researcher and as a physician scientist, I think it's my responsibility to stick to what I know. And to the best of our knowledge today, fruits are not associated with diabetes. If somebody has raging diabetes and they have difficulty controlling their blood glucose levels and their A1C levels are very high, I think they should be cautious about consuming fruits, especially fruits that are very high in sugar, like pineapples and grapes and mangoes. But for the general population who are not really suffering from diabetes, I think when you negate fruit, you negate so many other phenomenal compounds that your body needs to grow and thrive. And from different population studies, we know that women, especially if they eat at least 3 pieces of fruit, their chances of breast cancer, colon cancer, stroke, Alzheimer's disease actually goes down significantly. Take blueberries, for example. Blueberries actually are amazing fruits. They have the necessary phytonutrients that help your brain cells. So for me to kind of paint it with a broad brush and say fruits are not good, I don't think I'd be, sticking to the data.
As you can see, we don't like the broad brush.
Based on your research in Alzheimer's prevention, a few years ago, Neil Bernard, a whole food plant-based author who is very well respected, wrote a book about, I don't know what it's called, brain power,
Power Foods for the Brain.
Thank
yes.
you. Power Foods for the Brain. And in it, he kind of said something that there are certain supplements that he negatively correlated, that he said you should avoid. So in terms of an anti-dementia Alzheimer's diet, what specific supplements would you recommend that we make sure to get, and what would you make sure to avoid?
I think I described it in the talk. I think some of the supplements that are associated with better brain health are vitamin B12, especially for people who are on a whole food plant-based diet, and also DHA, an algal-based DHA, omega-3 fatty acids. Recently, turmeric has come into play as one of the most anti-inflammatory compounds out there. The vitamins to neglect or to stay away from, I would say any vitamins that you're not deficient in should be neglected. There's really no need for us to take extra amount of vitamins, especially fat-soluble vitamins, because they concentrate in your body and they're not as benign as we all think they are. They can concentrate in the body and they can cause harm. Specifically, vitamins and minerals or a combination of minerals that have iron in them. Iron deposition has been implicated in Alzheimer's and Parkinson's disease. So that's the one that I would be cautious about.
If someone already has dementia or early onset Alzheimer's, is that it? Is there such thing as reversing the condition or just slowing it down?
No, there's no reversal of Alzheimer's disease. So I want to be very clear about that, because a lot of people think when we talk about prevention and reversal of cognitive symptoms, it's in the context of no disease in the brain. Once Alzheimer's sets in, a majority part of the brain has already been riddled with the bad proteins, amyloid or tau. And it's very important for people to understand that when disease manifests, the damage has already been done significantly, whether it's amyloid or vascular damage. It's usually in the mild cognitive stages, which is early pre-Alzheimer's disease, or even before mild cognitive impairment, that lifestyle matters and it makes a big difference.
And the reason we're saying this is because there are people that are making that claim. And why is that important to say? Because there's a lot of money to be made. Remember, this is the fastest growing disease. And if anybody that can give you a bunch of pills or combination and find certain combination of holes in your head that they can only fill with their vitamin concoctions, that's playing on people's hopes, and it's false. The only thing that's been shown that in early Alzheimer's, as Ayesha said, you can't reverse it, but you can slow the progression down as much as 30-something% with intensive lifestyle intervention. But that's intensive. And even there, you have to kind of think, does this person want to go through that kind of a challenge at that stage in their life, where their whole diet is completely changed, their exercise routine, their daily activities, everything has changed. So even that has to be within that context.
We had the other day someone named Professor Thomas Seyfried from Boston College, and he was saying that that cancer is not a genetic disease, and that the problem with cancer is you got to starve the cancer cells and take away its fuel, which is glucose and glutamine. And then we also had someone named Alan Goldhammer who said that he's had fantastic results with water fasting. And then we had Brian Anna Marie Clement from the Hippocrates Institute who said they've had fantastic results with no sugar, raw food, green diets. Do you think that these same approaches that they're saying are effective in preventing cancer are the same things that would be effective in preventing Alzheimer's? Do you agree with water fasting, raw food, green diets, or a diet that eliminates glucose and glutamines as much as possible?
So I worry about one-off studies, including our own. I said I didn't even say it in our study. In our book, we did a cross-sectional study of 3,000 people. You remember that the whole coconut oil revolution was based on an anecdote of one. We had in Loma Linda, in a place where 50% of the population, 25,000 people, are vegetarians. And they have nowhere else to go except us. And it's not a problem of access. They're highly educated, so they know that if you have disease, they have to come to the clinic. We had 3,000 people who had dementia over 5 years that came to me and us. And we collected data, lifestyle, everything. Out of that 3,000, if statistics were null, meaning that there was no effective lifestyle, you would have to see 1,500 people who were vegetarians that developed dementia. But guess how many people out of the 3,000 were vegetarians in that population? 9. I gotta figure out my fingers first. 9 people. So that's an amazing piece of data. That should be on Time magazine. But we actually published it as a cross-sectional, as anecdotal data. That's it. That piece of data we published as just anecdotal, like as if we passed it off. So just because somebody has done something in their clinic, it's wonderful. It's qualitative, it's a first step. Other people should actually follow it, repeat it, make sure that it's repeatable, and so on and so forth. And then we come out and say that this should be applied to this field, let alone other fields. So this is true health. So I gotta speak in the totality. So there's a lot of people that say they did a lot of things in their clinic, including us, we could have said it. But it's really important that everything is reproducible. Now, on a different side, on a hypothetical side, things like fasting, water fasting, and other things, there's definite evidence that starvation of cells, be it through fasting or other means, has a direct effect on senescence, and senescent genes or longevity genes, the epigenetics of genes. There's no doubt. But I worry about us focusing on these nuances like fasting, because as a public health person, I'm not going to institute 36-hour fast on 300 million Americans. So if that takes the same weight as something that is applicable to the bigger population, which is a whole food plant-based diet, it's taking away space. It's taking away attention space. So it's good. I think it's definitely effective. There's been enough studies that show that fasting is effective across multiple diseases. But as a public health measure, I don't think it's going to be something that we should promulgate. That's the complexity that I wanted to kind of introduce there. I'm not very fun. I'm not going to, yeah.
So are you saying, based on your lecture today, that eating animal products, beef, chicken, dairy, eggs, and fish, results in higher blood cholesterol, and higher blood cholesterol is correlated with higher rates of dementia or Alzheimer's?
Yes.
I heard a debate on the Joe Rogan podcast between Chris Kresser and Joel Kahn. And in it, what Chris Kresser was saying was, look, there's been 9 studies on people who lived a long time, and there wasn't a higher death rate. He was saying that even if people had higher dietary cholesterol, it didn't mean it meant higher blood cholesterol, but even if it did, it wasn't necessarily correlating with higher death rates. So he was making it that it wasn't a problem having higher cholesterol rates.
Well, after that conversation, there were multiple doctors, including Dr. Garth Davis, Joel Kahn himself, and so many others who actually showed that the data he was quoting was so flawed that it was just unbelievable. The meta-analysis that Chris Kresser, by the way, who's not a scientist, was presenting was, completely negating important factors that have been established as risk factor for heart disease and for cardiovascular mortality. So I wouldn't change my mind based on that conversation because it was quite flawed.
The population is so Dr. Longo, who speaks about the fasting, brilliant doctor. Although I'm not a big fan of pushing one concept too much, but there's no doubt about his science and and it's a book to be read. One thing he says is incredibly important. When you're looking at different studies, different fields, you have to look at their data differently. If it's physics, you can look at one set of data and be fairly certain. It's physics. It's much more targeted. When you're looking at nutrition, you have to look at it very differently. You have to look at population data, historical data, retrospective data, cross-sectional data, randomized clinical trial data, as well as meta-analyses. Not just one element. Because when you look at it in totality, you get a better picture of truth than if you look at one element at a time. Because one element can be manipulated, as I showed you already, and it's being done now massively. There's the conspiracy. It is. And one set of data might actually, it's like that elephant and the 7 blind men. One is touching against a flat animal, another one is a long animal. And so they might be looking at it in a myopic way and not in totality. When it comes to nutrition, whenever you hear these people talking about one little set of data or this data or the meta-analysis, they're looking at it in a flawed way. And on top of that, they're holding away data that could actually change the outcome. Look at the totality. Population study after population study shows that cholesterol and fat has led to dementia. Change in populations and their diets, which is the paradox component, affluence paradox, has shown the Japanese that were healthy in Nagasaki, when they were westernized, they changed. India changed. Nigeria changed.
China.
Okay, that's the population. Retrospective studies have shown this consistently until 2010. What happened? And Joe Rogan kept using, like as if he was a new scientist, new data. When did we have new data and old data? What does that mean? Where we lost? Data is data. That was so flawed in an argument, and that should have been challenged. That data is data. By the way, a lot of the data that we have on whole food plant-based diet is actually more profound and more prominent after 2010 than before. So there's no old data and new data. There's some new data that's being looked at in a flawed way, and it's short-term, especially the keto diet. Show me any data that shows that long-term keto diet is beneficial, long-term. Any data, none. So it's critical that we look at the field and look at the science within that field. Again, complexity. Sorry, I'm not fun. But it's the complexity that we have to look at. It's not going to be found in one study or somebody saying that this is a new data that's come out and shown us this. When you have 100,000 people in Adventist health study, over 50 years, that shows that a vegan diet or a plant-based diet has 50% reduced rate of dementia, unless there was a conspiracy somewhere that data could not be flawed in any way. And there's many other studies like that.
When I hear an author talk about changing the diet and they show me the studies, I get very excited and I think, wow, this sounds great. But then when I heard you today say things like sleep, exercise, emotional health, and sunshine could help, I'm thinking, does everyone just say that because it's like, it's be positive, have community, get sleep? Like it sounds like, yeah, that sounds nice. Is that fluffy? Like is sleep a fluff thing? Like do I really need to get 7.5 hours? Can I get less? Do I really need sunshine? Do I really need to be emotionally healthy? Or can I stay angry? Is exercise really a big deal? Like is this like, feel good type of stats, or is this hard data that will prevent Alzheimer's?
Do I look like a fluffy guy?
No.
No, okay.
No, one of the advantages of living at this day and age is that technology has helped us identify markers of disease and markers of lifestyle better, and these concepts are not fluffy anymore. I remember, and I'm not that old. I graduated from fellowship in 2015, and I remember that a lot of the professors and doctors used to laugh at the concept of meditation and sleep. I mean, we took pride in not sleeping. It was like a competition. You slept 4 hours, I slept 3 hours. It was like that. But now, with markers of inflammation, with neuroimaging showing inflammation in the brain, with, blood tests that show oxidative damage to the brain, we actually can measure how these lifestyle factors, such as sleep, such as meditation, having love and community and sense of belonging in a community, how all that actually affects your brain health. And they're incredibly important, to the point where sometimes we kind of, put down nutrition a little bit so that people can pay attention to all of these other things. So yes, nutrition is incredibly important, but if it's not done in the context of a complex, multifaceted approach, which looks at exercise and which considers stress management, my goodness, the changes in your cortisol and adrenaline levels and how that affects your hippocampus, which are the areas of the brain that encode memory, and how it shrinks your brain. If you don't consider that, then it's not a complete health approach.
Sleep apnea is epidemic. Sleep apnea is lack of oxygen to the brain. If you have sleep apnea, you could eat a truck full of kale and it won't do any good.
I'm glad you got real fluffy and we got love finally. You actually said love.
Yes, absolutely.
She's sitting next to me.
There are a lot of studies that having a partner brings longevity in general.
Yes.
Apparently there's many different kinds. And it's interesting. I mean, we human beings, we're meant to take care of each other. We don't do all that well on our own. And even something as simple as the rate of death from, I'm blocking on the terrible skin cancer.
Melanoma?
Yeah, on melanoma, people do better if they have a partner. And one of the reasons is that a loving partner is likely to spot your melanoma before you do. So there's a lot of different ways that we humans take care of each other, and there's a lot of research on it. I have not, incidentally, I've been so busy fighting the drug companies, the shock machines and all, that I haven't put together as much as I want the data on love. But there's a lot out there that suggests that.
Absolutely.
You've seen that. Do you talk about that, about the relationship and longevity? Because you may have researched it more than I have, I'm sure.
On the negative side, people who have, I go back to the negative side, people who have dementia, their partners, their caregivers, die 60% faster than the patients.
Oh my.
But also, people who are married actually have lower rates than people who are not married as far as dementia is concerned. They can push the disease further back. So the commonality is very important, how we share. What is the common factor? Why would two people who are married, if a partner has dementia, their other partner has a 600% increased risk of developing dementia as well. That's not genetics, not in most part of the country. I'm from Pittsburgh, so.
Yeah.
But why? So what's going on? Shared risk factors, food, even activity levels, even energy levels,
Stress.
levels, everything is shared, and they contribute to 600% increased risk in the other partners, the disease. So yeah, and on the other side, love, as far as chronic diseases, it comes up over and over again. When you have a partner, in fact, we have a brain assessment. One of the questions we ask is marital status and love and connectivity, because it's been found to be that significant when it comes to cognitive diseases.
So if someone is depressed, and there's two choices, and you could say someone depressed or even someone not depressed, how real is sunshine? Is that just like, it means nothing? Like, should I go out of my way to stop being productive each day and go take a 45-minute walk and get sunshine? Is that like critical, or is that like, it's nice, but it doesn't really affect your life or your health, or should I take an antidepressant? So for depressed people, do you recommend antidepressants? Do you recommend walks in the sunshine? Do you recommend both? What's your thoughts?
Do I have an hour? We now know from the controlled clinical trial where we've looked at, even with the drug companies trying their best, and let's say they do 6 trials and they come up with 2, which is what the FDA needs. So they get 2 trials that the FDA thinks are good, and they get the approval, and they get 4, 5, 6 they've
Talk
done.
into the mic. Talk right into
We
the
get
mic.
4, 5, or 6 that they've done that they're not using. First of all, that's not science. I mean, the whole process is evil. The whole process is wrong. It's bad. It's calculated to sell poisons
The tattoo today.
to people. But now we're doing meta-studies. Some of my colleagues have been doing the meta-studies where they get all the FDA studies. And when you get all the FDA studies for antidepressants, they don't work. They do work. It's depending on the studies, 30, 40% improvement, but it's the same improvement as the placebo. Now, if you give a sugar pill, that's the data. But suppose you give a placebo that gives you a dry mouth and blurry vision, in which case you think you're on a drug, and the doctor thinks you're on a drug, because double-blind doesn't work. The doctors can figure out who's taking Prozac and who isn't, or who's taking whatever drug, because they all have side effects you can see. But if you take an active placebo's better. And it isn't killing anybody. I think that the entire antidepressant thing is just a giant fraud, so just forget it. And some people get a brief high from the brain damage. I mean, why does a person get euphoric and feel the best they've ever felt in their lives if they've been on a pill for a day or two? That sounds like a catastrophe. And it's often a harbinger of mania, a very destructive process. Or people get apathetic and they feel finally they're not suffering. And I've literally, most of the people who come to me are on drugs. Most of the people who come to me to get off drugs, so I'm dealing with drugs all the time. And you have the husband who's been brought in by his wife, and she's just desperate. He doesn't love her anymore. They don't have sex, but they don't have romance. They don't have love. And she says to him in the office with me, "You don't even love the dog anymore." And he says with heartfelt, "But I don't feel like killing myself." So he's got this idea in his head that it's either kill himself or take these drugs. But somebody who comes into a therapist or a nutritionist, I think, or a trainer who's full of optimism, because what is depression? It's hopelessness. It's, I see no way out. And it's so bad the way I am, I want to kill myself. And that can last for 10 seconds and people kill themselves. People kill themselves on the first dose of Paxil. I had cases like that. The destructive forces make them so crazy, they can't imagine living. So you give hope, you give love, you give optimism, you remind the person on the first visit what their assets are. So most therapists on the first visit, they're taking some notes and they're finding out all the stuff. And I like within 3 or 4 minutes with a depressed person tell me about your assets. Tell me what you've done, whom you've loved. I'm right away looking at the future and who they are and finding things I like about them, because it's all about hopelessness. And And it's actually, depression's one of the really easy things to treat if you are not depressed. In 1968, I got divorced and I was depressed. And it was the only time I had suicide attempts in my practice for 40 years. Never again. And then I had one more.
Talk to the mic.
I had one more, I don't know, 40 years later with somebody I barely knew who just called his wife and she said, "I'm leaving you." And, you know, he wouldn't come in the office. He wouldn't go to the emergency room. I said, can Ginger and I come over and pick you up and take you to the office? And he said, "Oh, yeah, we'll do that." So, and we got him through all of that. But, you know, an interested, caring, involved human being is what depressed people need. And it isn't necessarily therapy at all. People do it through religion. They do it through exercise. They do it through nutrition. And a lot of the effects we see that we attribute to something are actually the human interactions surrounding them. You've heard me speak, so you know that Pam's diet changed my entire physical health and got my wife over ulcerative colitis. So you know I'm a believer in that. But people will say, for example, my child was depressed and I took away his yellow dye number something, or my child was hyperactive and I gave him a new vitamin or something. But what's happening there, it's the first time the parent had the moral courage to actually tell their child to do something and to know they were right. And they had to do it. It doesn't matter what it is. Once you get involved with your child or your loved one actively, it makes things go better. So, yeah, if we just tapered people, we could throw away the antidepressants completely, move toward exercise, nutrition, and anything, and not just therapy, anything that raises us spiritually.
As an answer to you, wonderful. One of the best things you can do, and this is not soft, it's data on exercise repeatedly has shown that exercise is better than any antidepressants.
Oh yeah.
And then sunshine. So I say a morning brisk exercise with a loved one is the best medicine you can have. You have the social component, you have the exercise component, you have the light component, and that does work. These are not soft concepts. You take each of these independently, there's data. Combine them together, there's definite data. Create a community, that definitely is effective. We met thousands of miles away while she was with Doctors Without Borders and I was with US Forces and the World Bank. We went to Afghanistan, and I was in Reston, Virginia, and Bethesda, Maryland at the time, NIH. And every patient that would come to me would be on antidepressant, especially the women in Bethesda, lots of antidepressant. Then we go to Afghanistan, and I'm creating the most successful women's empowerment program in the world. It's actually published. And we go to this place where women are not even allowed to leave the close surrounding. And I'm offended at many levels. We won't get into that part, but whatever it is. And I tell you, I felt more laughter and heard more laughter in that little enclave than in Bethesda. What's going on? Obviously, that's not good, obviously. And I did everything in my power to whatever. But it was community. Community, any kind of community you can create is the most effective thing you can do. Community is everything. In fact, the blue zones, the common denominator of blue zones, as much as we would like to say nutrition, and it is a big factor, as much as we would like to say anything else, it is community, whether it's religious community in Seventh-day Adventist or other kinds of community in Japan and Nicosia and other places. It's community. Building community is the most effective antidepressant.
And I
by
think
far.
I think loving community too. I think we need to distinguish, because nowadays we have a lot of hating communities, and we have to. It's got to be loving community for sure.
That's true.
Not politically centered.
Okay, I would like to, if someone could say a question in 30 seconds and not tell us a story, just direct 30-second question. Only people that can say a question in 30 seconds, no matter what, without a story and without a follow-up question, could raise their hand and we'll call on you with those strict rules, no exceptions. You can call on.
I'll start with you.
Wait, hold on, wait for the mic.
Hello. If somebody's on a psychiatric drug, I think
Speak up, please.
Sorry. If somebody's on a psychiatric drug, a serotonin drug, I guess, how do you phase it out? How do you get rid of it?
I'm not hearing you, I'm sorry.
If somebody's on a psychiatric drug, a serotonin
I think
receptor
it's
inhibitor,
serotonin,
how
I'm
do
not
you
sure.
phase it out? Am I getting it right?
Yes.
Well, it's a good question, and you'll see it's consistent with every way I approach things. The main thing is to, if it's no emergency, is to go at the pace of the person who's withdrawing. All the big mistakes are the doctors who say, oh, you want to come off the drugs? All right, half them to this week and half them the next week, and that's it. They're often punishing their patients with good intentions, of course. But I'm going to tease you forever. But first of all, I build a relationship. Because a person who's coming off drugs is going to go through potential problems. Then I help them build relationships with other people. And I won't withdraw somebody who's in a lot of trouble and has nobody to be with them at night. I just don't know how to do it. I had a private practice. If they could go to a hospital, it's not usually possible. So I help them build a community around them as much as possible. I'll even talk with a member of the family, actually, and tell them what the adverse effects on withdrawal might be. And I'll give my cell phone to that person who's withdrawing, and I'll give my cell phone to the person who's living with them or calling them and so on. And I tell them that the reason you failed before and the reason you're so afraid, because those are the people who come to me, the reason you're so afraid is it wasn't under your control. And the way I'm going to help you put it under your control is I'm going to give you the tiniest possible reduction the first time as I can figure out to do with you and how much you break up your pills and whatever. And let's see if you can just do a little withdrawal and it doesn't affect you at all. Give your confidence going, get your hope going, and we work it out. And by the way, I got a whole book about it, psychiatric drug withdrawal. And so you go slow, and then you have I don't want to get into it tonight unless asked, but you get into the complexities of which drug, if there are several drugs and all of that. In general, you want the sleeping pills to go last because when people have to deal with insomnia, that just wrecks everything. And basically, I try to help them get rid of the antipsychotic drugs first because they're so horrible to the human being. But it's basically a collaborative effort with support around them in which they go slow enough to go at their own pace. So literally, my job is usually, well, you want to go that fast rather than pushing it faster. And then I don't get mad if the person says, this is going well, doc, and I have to tell you, I stopped them all yesterday and I'm doing fine. And okay, I don't get mad. I say, well, it was under your control. And if they get messed up when they do it, I say, oh, it's okay. Learn from that. So it's a relationship where you're really helping the person along at their pace. They have to have the power. You want the person to feel in charge, and it will be their first time in their lives, possibly, that they felt in charge with a physician, and definitely with a psychiatrist.
We'll take a question from this side, and then we'll come back here. Yes, sir.
A microphone. It's dangerous to put a microphone in my hand. So my mom is 96 and a half, and until she was 93, took care of all of her own ADLs. She slipped and fell outside on her own and had a traumatic brain injury. So she's been on Seroquel and Aricept since she got out of rehab. While she was in rehab and involved in activities, she seemed to be doing better. Is there anything that can be done for a patient like her at this point? She goes in and out in terms of cognitive ability.
First of all, I won't speak to the Aricept. Maybe I'd like to see you two do that. Seroquel is a terrible toxin. It should never be given to anybody who has any form of brain compromise because it will increase the odds. And how old is she? Well, she'll probably die very quickly on Seroquel. And there were warnings not to give any of these drugs.
Black box warning.
Well, she may be, but I can tell you that the science on this is horrible about the rapidity of death on elderly with dementia, so much so the FDA has a black box warning for all these drugs. So she should get weaned off Seroquel. I think I can say that without practicing medicine. Look at the black box warning about that. But this happened to my mother-in-law, Jean, and she lost a lot of cognitive function acutely at 94 when she fell and had a concussion. She already had some compromise. And we found that just loving the heck out of her and surrounding her with people, Medicare paid to bring in somebody to do strength training at her age. They paid to bring in briefly rehabilitation of all kinds of different people. The main thing was she loved the people. And she actually got stronger to prevent more falls. So a huge amount can be done with the elderly in terms of bringing in services, bringing in love. And the main thing I did was what I've been talking about. It's just everybody needs the same thing, I think, in human services. I just told her she's got to have hope. Hey, Mom, you don't have hope. Where are we going? You got to have hope. You love me. You got to have hope. You know, and I'll do that with my patients too. It doesn't cause guilt. It causes a sense of being wanted. And we just got really involved with her, and she's been, so far, thank God, really doing well. But that could change momentarily. I don't pretend that it couldn't.
I fully agree with everything you said as far as medicines. That antipsychotics, 93, it's a black box warning. The mortality rate goes up, and then they attribute it to something else that caused it, but actually it was the cause.
Yeah.
Aricept doesn't do anything. So we wrote in the book about islands of consciousness. Can you hear me? Okay. If I get any closer, you're gonna get so. So islands of consciousness. We have these islands of awareness. She told me right away to be brief, so I'll try to be brief. So we have these islands of consciousness that we build. If you're a musician or music teacher, that's one of your big islands. Family's a big island. If whatever you did is a big island. We had a patient that had dementia, then got UTI for 4 months, had not spoken. We went to her, I did rounds, I went to her and I said, Miss Collins, that wasn't her name, I will just use that. Miss Collins, talk to me. And the residents were getting irked, like, she hasn't spoken in 3 months. I said, Miss Collins, I said, repeated this. I said, tell me about her. They went and the research came back, they said she was a music teacher for 60 years. I said, Miss Collins, again, no, nothing. Miss Collins, who was a better composer, Mozart or Beethoven? No response. And the residents by now are getting very irked. Miss Collins, who was a better composer, Mozart or Beethoven? And all of a sudden I see a flicker. And she, in a very soft voice, says, what a stupid question. She didn't come back to normal, but that was the beginning. Music in the background, talking about music, bringing her students and everything else. There's a lesson there. That was a big island. What is island? Island of consciousness, all the elements that connect to that thing that you're familiar. Familiarity. Familiarity brings more consciousness. Familiarity brings more connectivity. Familiarity brings more awareness. So more Aricept does nothing. And the antipsychotics, all of them, they're sponges. They're dopamine sponges. They're basically going in and sponging out dopamine. So how could that be really good? Yeah, it does silence the mind, but it's not going to take a 93-year-old to awareness. What will bring a 96 or 93-year-old into awareness is awareness around the things that she was aware before. Build those islands again. Bring familiarity around her again. And what's the biggest familiarity? Love. What's another familiarity? After language abates, even after all language abates, guess what's left behind? Music. This is not soft concepts. It's written in many papers, repeatable papers. So that's how you bring people back, not with antipsychotics or Aricept. Finally.
Okay.
Good evening. I have a question. What are your thoughts on commonly prescribed drug Wellbutrin, especially considering doctors normally prescribe it for quitting smoking? And wouldn't be benefits of quitting smoking outweigh like outcomes of and danger of Wellbutrin?
Can you repeat the question? The drug?
Wellbutrin.
Wellbutrin.
Well, and Shantex, yeah.
Wellbutrin for smoking cessation.
Well, and
That's-
Shantex, I can address that, you can address that. Shantex is the drug that produces probably the most abnormalities in the mental sphere of any drug that's been studied at the FDA. A paper by Thomas Moore found that Shantex was the most associated with violence of all of the hundreds of FDA-approved drugs, right at the top. And it was interesting to me because, those are pretty normal people that the drug is driving over the edge, but they are also going through withdrawal from cigarettes. So Shantex is a very dangerous drug. And when a drug makes people violent, it's making them do lots of other things. Violence is just one expression of aberration. And Wellbutrin is a very stimulating antidepressant. We shouldn't even use words like antidepressant because they don't do it. But it's a very stimulating neurotoxin. So it can produce the whole array of things: suicidality, aggressivity, and then there's a litany of the amphetamine-like stuff that's in all the labels: the agitation, the anxiety, the impulsivity. It's an activation that actually came out of one of my papers, practically right into the label. It's very amphetamine-like. So the smoking cessation drugs are really poor, and again, the triad of exercise, nutrition, and some spiritual coming to grips with it is probably certainly a lot safer.
Absolutely. I'll take a question. You had your hand up. Microphone, please. I can repeat your question if you want.
Hello. As people age, their renal clearance goes down, and they're put on these drugs with increasing dosage to get more symptomatic effect. What happens to a patient when their renal function declines and they're on like all three Alzheimer's drugs at the same time? Let's say?
So the question was about renal clearance and the effect of medication on somebody who has renal clearance issues, where they can't really clear off the byproducts of medication and what happens. So there are different medications that get processed in the body in different ways. Some of them get out of the body through the kidneys, through the urinary, through the renal system, and then there are medications that are processed by the liver or the hepatic system. And obviously, the ones that affect the renal system, they get toxic in the body. A lot of medications that are used for seizure prevention, that are used for diminishing consciousness or abatement of anxiety when it's related to Alzheimer's disease, can cause a lot of damage as well. So that's why it's very important to find out the baseline of the patient, where they are, whether they have any renal issues or hepatic issues, and then deciding, not to give them a lot of medication to begin with, being more lifestyle related. But if you have to choose somebody, it has to be, if you have to choose a medication, it has to be based on their baseline kidney function and hepatic function.
And liver is very important. You've stressed the kidney, but most drugs, I think it's fair to say, are detoxified in
Correct.
the liver. So
Yeah.
it's the liver function that you also really have to look at. With psychiatric drugs, other than lithium, I can't remember offhand one that isn't detoxified primarily in the liver.
Right, and Keppra, which is used for seizure prophylaxis, is processed by the kidneys too. Yes.
If you were to diagnose early Alzheimer's in a patient, would they have to go to a neuropsychologist? That's one question. My second question is with Sunshine, obviously people are using sunscreen so they prevent melanomas. So you suggesting like a low, less, not to wear 50, to wear maybe less of a sunscreen to get the sunshine?
You can use sunscreen. I'll do the. So early onset Alzheimer's. If you've been diagnosed, this is the third time I got that question today. There aren't that many of those. So be very careful. If somebody gets diagnosed with early onset Alzheimer's, you must go to a neuropsychologist and go to a clinic, a academic setting, because it's misdiagnosed. A great number of times it's misdiagnosed. It could be severe depression. I mean, depression by itself, because attention is the gatekeeper of consciousness. Anything that affects attention is going to affect memory. And depression can get so bad that you can't focus to the end of the sentence. Therefore, they're going to diagnose you as dementia. So they're going to put you into that whole pathway. And there are a lot of other things that can cause early cognitive decline. B12 deficiency, thyroid disease, infections, lots of other chemical. So it should be diagnosed, it should be evaluated, it should be evaluated through a neuropsychologist in a good setting, because I would be quite incredulous of that diagnosis unless it's been through a good setting, a good venue. Yeah.
My guess would be that the vast majority of early signs of cognitive dysfunction are psychoactive substances, and they may not necessarily be psychiatric drugs. There's plenty of other drugs that cause cognitive problems, and that probably the most common cause of early.
There are medications that cause it. There are substances that didn't affect you before, but now with aging, you're going to hit that precipice. I've written this thing called the precipice phenomenon. Yeah, you didn't get to the precipice right away. You walked to it. And then there was a precipice. You had a UTI. You ended up in the emergency room and disoriented. Oh, it's the hospital that did it. No, it was the precipice phenomenon. So the pharmaceutical component, the medication, the psychoactive stuff, depression, anxiety, lots of other things have to be ruled out before you're giving the diagnosis of early onset Alzheimer's.
Okay, right here.
Hi, I have a friend that's a big fan of yours, Dr. Breggin.
I'm having trouble, so speak up.
Big
I'm
fan.
having trouble too, apparently.
Okay, he's a big fan of yours. He's been off psychotropic medication 4 years, but he's describing agitation on a daily basis and 2 suicide attempts. Trying all those wellness, nutrition, acupuncture, a good support system, doesn't seem to be working. So what's next steps when the wellness strategies aren't working and they're in the suicidal ideation, do not want to take medication? What other alternatives then are your next steps with this?
Well, first of all, there's all of life, and I really want to emphasize that. People find their way through so many things, religion and God and their pets, really their pets, often nature, a friend. I mean, there's so many things that pull a person out. But looking at it just psychologically, people who go from one place to another for help and don't get help have reasons for not getting help. So the thing to address, and well, I don't know what all of that means. Agitation, anxiety, I don't know what it means. But I can address the idea that this person goes a lot of places and nothing helps. I can't address why she might be agitated. She might be agitated because she's subconsciously remembering child abuse, or the person that she knows who you think is loving is beating her. Who knows why somebody's agitated? But I do know the pattern of nothing helps. And nothing helps has to be addressed on the level of what is keeping you from taking charge of your health care. What is keeping you from facing things and doing them? There's some benefit, in your mind about this, and you have to be very loving about it. You cannot undermine, so easy to undermine somebody, and nothing undermines people faster than saying, it sounds helpless to me. So I've avoided that one, except when I'm not on my toes. But you want to help the person see that there's something more going on here. And it's often a plea for being rescued, that comes out of the child's mind. For God's sake, please, somebody. And I'll explain to people that the worst thing you can do for yourself is be helpless with other human beings, because they can't bear it. If you go to somebody and you tell them no one's helped you, and you go to finally somebody's going to call a psychiatrist or something, because human beings get very distressed when people just won't respond to anything they do, to that kind of helplessness. So there's a kind of an interesting thing to look there. May not be relevant here, but it's relevant to all of us, because we all at times wish we could just say, it's so bad, would somebody come and help me? Now, in my case, it's wonderful because Ginger either says, stop being helpless, or she says, here I am, depending on her mood.
We'll take a question from this side. Yes, ma'am.
You talked about high blood pressure and the effects on Alzheimer's. What about low blood pressure?
So low blood pressure in the setting of calcified arteries is a bad thing. If somebody has had atherosclerosis, which means hardening of the arteries or narrowing of the arteries, especially in the neck and in the back of the head, that is essentially the major arterial supply to brain. Say, for example, if somebody has had narrowed arteries and you figure that out late in life when they already have cognitive impairment, you don't drastically lower down their blood pressure. And low blood pressure can actually cause fogginess and confusion, so you tend to keep their blood pressure high. But that all depends on how clogged the arteries are. Once these reverse, and we've done that with lifestyle, so on and so forth, everything that we talked about, then it's ideal for blood pressure to be low, because we have millions and millions of arteries the size of your hair that supply billions, not millions, billions, that supply oxygen and nutrition to the brain. And these collapse. These arteries actually collapse on themselves when blood pressure is very high. So, the day we find out optimal blood pressure for every individual is when we will make major changes in healthcare. I cannot wait for technology to actually help us ascertain that.
We are doing blood pressure is a terrible chronic
It's a really
disease.
blunt way, yeah.
We have no tools of really truly addressing blood pressure. It's not just high blood pressure or low blood pressure, because both can be bad.
Yeah.
It's the high blood pressure and low blood pressure in the context of your previous pathologies. And how are we addressing it now? Every 3 months, taking a blood pressure measurement in a clinic, and then your medicine's adjusted according to that, which it doesn't get any more blunt than that. So we're doing a poor job. We say one of the best things you can do is to take a blood pressure measurement at home of yourself, maybe even twice a day, and write it down, and then take it to your doctor. Make sure that the tools you're using is valid and is tested to it's accurate. And then you take that to the doctor, and then they can make the adjustments. Not once every 3 months at a clinic, which means nothing.
I'll take a question from this side. Yes. Oh, I'm sorry.
Wait,
I
hello?
apologize. I'll get back to you soon.
Oh, hi. Regarding drugs, I have a dear friend who's been, I'm sober 27, clean and sober 27 years, so I don't do anything, which is really hard. It's a lot of work. And she is overweight, and she has started taking, through her doctor, which will give her anything, amphetamines. Now, I always heard the expression speed kills. And she's very stubborn. She even suggested, because I'm kind of naturally hyper, oh, you should go on it. It's really great. Helps you focus. And so I know that's not what I want to do, but why are amphetamines so bad? That's what I want to know, the science behind it.
Why are amphetamines so bad? Well, first of all, they don't help you focus. They shut down the rest of your brain so that you're able, with what you have left, to focus on something that's stupid and boring and you want nothing to do with. They recommend,
That's beautifully stated.
Thank you. So it's over-focusing, and we give children Ritalin, and they bear down on the paper and it tears. There have been studies of this. It's actually OCD. It's NIMH did the only study that ever looked at this, and half the kids on, I think it was simply methylphenidate, developed OCD during the process. And interestingly enough, about half of them got tics when they started really looking. So there's something going on with those basal ganglia that have a lot to do with OCD and tics, and then they're all being stimulated by at least by the dopamine effects. The other thing that the drugs do is they limit spontaneity. They may drive hyperactivity, but the person loses flexibility, loses the ability to think. One professor said to me, nobody writes a good paper on Shakespeare when they stay up all night and do amphetamines. There's something very rote that's going to come out of it. Beyond that, we have studies that the amphetamines shrink brain tissue. I mean, they do. And the studies start with the methamphetamine studies because that's what people are willing to do. And then it's very interesting, but not evil. When the studies come out for Ritalin shrinking tissue, they explain how it's helping. Really interesting. I see 2 studies out of John's.
That one is evil.
That's evil, right? It was, listen, you find these buried somewhere in my books. Amphetamines, they really do. They're not good for the brain at all. And they can produce violence and they can produce mania. And a person that is that hyper is in serious trouble. They get that hyper with somebody on the street and they're going to be in trouble. So they're terrible drugs.
And one little other thing, seizures.
Seizures too, yes. Thank you.
Oh, I'm sorry. Okay. Just don't trust me. It's too late in the day. I'm sorry. Go ahead. Yes.
He wants a job. Give the man some
I'm sorry.
autonomy.
Go ahead.
What's an absolute and safe way to remove heavy metals from the brain?
I couldn't hear you.
What's a really reliable, really effective way and safe way to remove heavy metals from the brain?
By not taking them.
No, but once they're in from whatever it is, mercury, whatever, what they've been measured, it could come from the dental mercury.
So you're talking about the process of detoxification. Chelation and detoxification have been studied, but not broadly. The body has its own internal mechanisms to get rid of toxic material if you give it the chance to. A lot of the chelation studies that have been done on copper and other heavy metals are done in the context of acute heavy metal poisoning. There are no studies that have actually looked at people who, say, for example, eat a lot of fish and then they have deposition of heavy metals in their neuronal tissue and they did something to get rid of it. If you don't produce toxic material to the body eventually gets rid of it. I hope that helps. It's not very exciting.
Something I'd like you to address is, how does this gentleman, how do you know you have a heavy metal problem in your brain? Because I'm not sure how we would know that, or whether it's somebody did your saliva or your hair and came up with this. So I think you should look at, is that reasonable? You should look at, where this come from, this conclusion.
How do you know you have heavy metal toxicity?
Or even if he does, he may have spoken about somebody else.
Or somebody else?
Well, because I did some heavy metal detox and I got better to a certain point. And then what I was taking, they stopped manufacturing it. And then twice I tried something else and I got really, really bizarre symptoms. I might have taken too much. Once it was like the vision field was digitized, little pockets of things pixelating, all kinds of crazy things. I don't know what was going on. Another time I was taking one that had EDTA in it, and obviously it was too much, but I took it what I was advised, and suddenly, I called somebody, he said I already called him 5 times, for help. So, of course, I stopped. So that was, the whole thing of correlation isn't causation, but that's pretty clear to me. And I'd had a lot of amalgams in the past. And also, it might have been not heavy metals. I was in India once when they were, they're spraying this big camps with, what was it, that's some pesticide that's banned here. So I could have absorbed who knows what there. But that's how I got to it. And actually the first clue was an intuitive doctor that this big clinic down in Washington, the doctors sent all the really difficult patients to this intuitive MD who'd gotten hit by lightning and became intuitive.
Okay.
And I called him and he said, "You're so loaded with heavy metals, I can't see past whatever else is going on." That's when I started the detox and started getting better.
Okay, that intuitive doctor thing threw me off a little bit.
Yeah, but the consequence of my doing it got me better.
So I don't know if I want to address all of that, but so I'll address the core concept. Heavy metal toxicity. Is there such thing as heavy metal toxicity? Yes, mostly from foods. There's not much evidence that dental caries and things or dental appliances cause heavy metal toxicity. There's not much data there. So if you suspect it, have all of these tests that you're hearing about for gluten, for this or that. Do it in a legitimate setting, in a setting where there's not an intrinsic bias towards finding an outcome, because they will find an outcome if they want to treat it. So heavy metal toxicity, and I have the lab that actually looks at people with potential toxicity. In years and years, out of thousands of people, maybe I found 2 people that had slightly elevated mercury levels. So it's much more overstated than is truly out there. So, and then get it appropriately tested. And then the other thing is, the idea of if you think you're toxic and then using the medicine as a way of seeing if the original disease was true is actually a little bit of a backwardness, because you will find the thing you're looking for, even if it's there or not. So be careful about treating diseases without even truly finding out if you have disease or not, because then you're going to be the subject of your own experimentation forever until you kill yourself. So it's really important that you get legitimate testing and truly get diagnosed and treat it only when you need treated. Because simple lifestyle measures work so much more. I think that's a good broad way to approach that.
I'm sorry.
You've been picked.
Yeah, you've been picked. No, he had his hand up for a while. I apologize.
Him or her?
Him. And then we'll come back to you.
Hi, thank you for being here. From what I understand you saying, there's no reversal of Alzheimer's and the onset of dementia once the plaques have formed, and the drugs...
Can you speak a little louder, please?
Sorry. From what I understand you saying, there's no reversal of the onset of Alzheimer's and dementia and reversal of the plaques once they formed, and the drugs don't delay the progression of the disease. How is it that your Alzheimer's solution then helps once the condition's been presented diagnostically?
Well, the first part is not controversial at all. There is nobody ever claims that there is reversal of Alzheimer's. And our book never says we're reversing Alzheimer's. It's a solution for developing Alzheimer's so that you don't develop Alzheimer's. And that's big enough. You know, that's, if we can, look at this. If we can move Alzheimer's in the population back by 5 years, we will have reduced the cost of Alzheimer's to society by half. That's a pretty good measure. We never want to make hyperbolic statements.
Okay, this crowd.
Let's make this the last question, then I'll ask everyone to make a final closing statement. So,
Okay. Let's pick you, sir.
Is the brain made up of essential fatty acids or a lot of fatty acids or fatty material?
Brain is made of a lot of fat.
Okay. Would fish oils be good for a brain?
Fish oils would be good for the brain, yes. But it's better from, like I said, from algae form, because where do you think that fish get the omegas?
Or essential fatty acids?
Yes, absolutely. But there's some people making these claims because cholesterol is not bad, fat is not bad, because your brain is made of fat, so therefore you need fat. It's the dumbest thing I've ever heard in my life, and I want this to go out there. It's ridiculous how that analogy is being made. Just because your brain is made of fat, therefore you need more fat. Your brain also has a lot of iron, so you should be biting on iron. I mean, that's kind of a... So a fat in a proper way, and whole food way, and a polyunsaturated way is absolutely beneficial, especially in omegas and DHAs, yes.
Okay, so you've all given your individual lectures. We very much appreciate you coming here. would you like to leave us a summation of final thoughts encompassing any final important pieces of information or conclusions you'd like to share with us tonight?
Why don't you start?
I'll be short, believe it or not. I think, first of all, thank you so much for doing this. It was a very different kind of experience. We've been in dozens and dozens of formats, and this is the one that I feel a little bit of tension, and I like that. That's the way it should be, because if you're going to get to true health, you got to be a little bit tense, and people, so that's beautiful. And I learned.
Not tense.
No. I meant it was great. I learned so much. And
I actually thought it was great too.
I did.
I did.
promise
That
you.
was an amazing beginning.
I'm reading every one of his books.
The first half hour here was the most exciting half hour I've ever had on a panel, and it was just amazing. Wonderful.
And I will definitely read every one of your books.
I already bought yours.
So I really think that most of health, not all, most of health can be achieved in the community and at your home through community, through whole foods, through exercise, through good sleep, and social mental activity. That's 90% of all health. If you just focus on that, you don't have to buy my book, his book, nobody's book. That's true health. And you will avoid all the side effects that are being hidden by the evil industries.
Well, I'm honored to be here. I truly am. With all the work in the hospital, as a resident, as a physician, during fellowship, I'm more passionate about sitting here in front of you asking me questions, and me trying to answer them to the best of my capacity. I'm very, very passionate about public health. So, Steve, thank you.
Sure, thank you.
For creating this opportunity for us to disperse information about real truth about health to the public. I think as far as summation of everything that we've been through, I've learned that truth comes out in dialogue. We should have more of these opportunities where we can discuss health measures and preventive measures in a very educational, comfortable, sometimes uncomfortable, but mostly comfortable and challenging situations. And the message to the community is, don't wait for a governing body to tell you what to do about your health. We all know, we've known for a very long time how to live a healthy lifestyle. And it's never too early, and it's also never too late to start it at home. And that health actually starts at home. The decision you make what to eat, the decision you make when to wake up and how you go to sleep and how you walk, all of that makes a significant difference in brain health, as simple as it may sound. So thank you, Steve.
Thank you.
I had a wonderful time, and I learned more from you too than just about anybody I can remember about whole bunches of things. And I'm actually going back home to deal with my mom, my wife's mom, in better ways, and I'm grateful for that. And I really enjoyed your willingness to have me intervene and make a statement and work it through and all. It was really great, and that first half hour I think is priceless on film. And one thought to leave you with: I like to think about how we evolved and use the standard of, well, what in the world made sense for 2 million years? What made sense for 2 million years from when we climbed out of trees and got here? And we were eating plants mostly. There's no cultures except for Eskimos and a few others that ate a lot of meat. And it's so clear we are basically vegetarians who scramble and get a little meat usually when we can. And the second thing is we had to move. We moved or we died. We were nomadic. We were on our feet. The women were out gathering. The men were out hunting. So we got to move and we got to eat well. And the communities for 2 million years were around families. They were not villages. It doesn't take a village to raise a child. It takes a family to raise a child. And I'm good that resonates. And what it really takes is a family to help a mother raise a child in the early years, and then to help a mother and father raise a child. And to be nursing, we didn't deal with that, to have mother's milk in the beginning. So think about who we were when you want to know where we're going. And we lived in relatively loving communities, though toward ourselves, maybe not the other communities, but toward ourselves and toward our children. And it's all what we're doing now. We're rediscovering and learning what human beings are made of, and we're made of good food, activity, and lots of love.
Very true.
Thank you, Dean, Ayesha, and Peter. We all appreciate it.
Thank you.